Dr. Patel has contributed chapters and cases to landmark works such as twin block functional therapy applications in dentofacial orthopedics by William J. Clark and faces and braces by Rebecca Clark, with his cases also included in Dr. Clark's thesis New Horizon in Orthodontics at the University of Dundee, Scotland.
Good afternoon, everyone. Thank you, Marimal Dental College and College of the Dental Science Mangalore and the Mangalore Orthodontic Study Groups. My lecture is a totally
Yes, sir, you're audible, sir.
My lecture is a totally on the clinical base, and I have given some tips regarding the how to register the bite in the different class 2 malocclusion cases. And neither I attend with the any college nor I am an academician. So my clinic is totally based on the clinical, my personal experience. And thank you for invitation given by me, and thank you for all of fellow colleagues for joining the programs. Thank you.
Good morning, everyone. Orthodontic fluid, the final culmination. The twin block functional therapy developed by the Dr. William Clark in 1975, a Scottish orthodontist. He developed the twin block appliance therapy, and that became a popular all over the world. Many of the severe skeletal deformity can be treated by the twin block appliance if it is a timely treated and properly educating the appliance therapy. This is my picture in 2017 when I visited the Clark home. He presented me a third edition of the twin block appliance. And the cover page is treated by me in the Rajkot. This is my privilege. Bite registration. Bite registration is a crucial part in a twin block appliance therapy for the sagittal activation as well as the vertical correction. Woodside in 1977, the mandible should be positioned protrusive approximately 3 millimeter distal to the most protrusive position that the patient can achieve while vertically the bite is registered within the limit of the previous space. This definition is only for the monoblock or the Robinson appliance activators. Roccobardo defined that quantify the normal physiologic TMJ movement as 70% of the total joint space. So even when you want to advance the mandible, the 70% of the total movement should be registered. Vertically, the twin block should be less than 5 or about the 5 millimeter in the premolar region or in the deciduous molar region. If it is less than 5 millimeter or within the freeway space, many a time patients are able to move the mandible into the retruded position and the effective correction will be sluggish. In case of the class 2 division 1 dip bite cases, in a moderate dip bite cases, 2 millimeter of incisional clearance should be maintained. Whereas in case of the severe dip bite cases, may not be possible to maintain the 2 millimeter of the incision clearance. In such a case, either edge to edge or underbite should be registered. These are the how the construction of the bite is produced. Make a ring with the modeling wax or alu wax. Heat it into hot water bath. Mold it into the upper arch. Wax bite should not be too firm, neither it should be too loose. It should be firm enough to formable. Upper and the lower midline should not be altered unless there is a mandibular deviation which is to be corrected. These are the few examples how to bite register in the different malocclusion. In a moderate class 2 division 1, where the overbite is up to the 10 millimeter and a moderate dip bite, a single activation edge to edge incisor relationship with 2 millimeter of the incisor clearance should be maintained. Where it is a 10 millimeter or less than 10 millimeter, you can advance the mandible up to edge to edge with keeping the interincisor clearance about the 2 millimeter. And in the premolar region, it should be a 5 to 6 millimeter in the first premolar region. Whereas in case of the severe overjet, more than 15 millimeter of the overjet, you cannot register the bite edge to edge. In such a case, if you move the mandible further forward, it may create the damage to the temporomandibular ligament. The median fiber of the ligament may be overstressed and may create the difficulty in maintaining the forward position of the mandible. In such a cases, half of the about 6 to 7 millimeter of the mandible should be advanced and registered the bite, and the further correction can be in the second phase after the initial correction is take place. Now, in many cases, there is a lot of space in upper anterior as well as in the lower. For many a time, there is a upper anterior, there is a spacing, and lower anterior, there will be a mild to moderate crowding. So, to register the bite registration in the forward position, first you should consider the what are the scope for the retraction is taking place when you close the space. Accordingly, instead of keeping a edge to edge relationship, you can keep it positive distance about 4 to 5 millimeter, so that after the advance in the mandible, remaining overjet can be closed by the closing or by closing the space in the anterior aspect. So that should be a consider when you are taking a bite registration with the severe amount of the anterior space. In case of the class 2 division 2, where is a severe dip bite, even in a severe dip bite cases, if you want to move the mandible forward edge to edge, there will be a severe open, the mandible will open in the premolar region, may not be comfortable to bite the edge to edge, or you cannot put the 2 millimeter of the interincisor clearance. In such a case, either you keep edge to edge bite or you can keep a overbite positive. After the correction, you can keep it edge to edge registration after the initial correction is take place. Or many times in a severe skeletal dip bite, mandible cannot advance anteriorly and you cannot register the bite properly. In such a case, you should prepare the anterior bite plate for 3 to 4 months. After the clearing or opening the dip bite with the bite plate, then you can register the bites for the advancement of the condition. In case of the class C twin block applies bite registration, if the patient is able to bite edge to edge, then and then you can attempt for the class 2 or reverse twin block appliance. If the patient is not able to bring the lower jaw edge to edge, one should not support to attempt to register the bite or should not be registered for the reverse twin block appliance. Fabrication of the twin block. Fabrication of the twin block can be carried out with the following step. Preparation of the clasp and label block. Usually 7.2 or 7.6 millimeter of the diameter of the stainless steel wire is used for the orthodontic clasp or a leg elbow, or it should be 0.032 inches in the diameter. You can prepare the Adams clasp, eyelet clasp, arrowhead clasp, or a leg elbow the same way. Acrylization can be carried out by a base plate either by the hot cure and cold cure. Cold cure is the more convenient and it requires less step to polymerization. So I prefer to have a cold cure acrylic for the base plate. Preparation and finishing of the register wax bite. As soon as you register the bite, it should be mounted onto the patient study model. Excess weight on the palatal as well as the buccal side should be removed. It should be planed properly in the model, and the carving, if you are doing for the interdigitation, you can do the carving on the wax bite block. Sectioning of the wax bite. I utilize the wax bite to convert into the bite block. So I have to finish and section the wax bite in a two part. One part in the upper appliance will remain the posterior bite block, and the anterior part will remain the anterior bite block for the lower appliance. That will be seen in the subsequent slide. Preparation of the plaster key. Either you prepare a plaster key, or you can mount onto the fixator, or you can make an index in the putty to help in the bite block acrylization. The next step will be acrylization of the upper bite block, acrylization of the lower bite block, finishing and the polishing. Take the bite from the model and place into the patient mouth to verify whether is there any error or not. Once the bite is finished, mount it onto the fixator or store into the refrigeration so any distortion should not be taken place. Acrylization of the upper and lower bite. This is prepared from the Colter acrylic, and the skeletal framework is the Adams class on the first molar and premolar in the upper appliance, and the eyelet class is given between the lateral incisor and the canine. For the lower base flat, interdental class is given between the incisor and canine. Adams class on the first premolar, and the interdental class or a half C class is given between the first molar and second molar. Lower base plate is extended up to the last erupted molar. As you extend the lower plate up to the last erupted molar, it holds the mandible properly, and you can control the flaring of the lower incisor because of the forward force from the lateral pterygoid muscle from the mandible. And the upper bite plate is also extended up to the last molar, and the midline screw should be placed. After preparing the upper and lower base plate, we should assemble the prepared bite register onto the model. You can see in front, right and left how they are snugly and properly assembled without distortion, or you can see the properly. You can see even the karmic for the interdigitation. And last, you can see the bite onto the lower model. Evolution in the inclination of the bite block. Inclination of the inclined plane is evolutes from 90 degrees to 70 degrees. The first twin block by Dr. Clark has designed with the 90 degree of the angulation. That was very difficult and not comfortable to the patient in opening and closing of the lower jaw. So it turned into the 45 degree. After turning the 45-degree inclination, again the forward holding the mandible was not that much efficient, and the patient was able to override the block. Ultimately, the 7 degree was the appropriate inclination to hold the lower bite block in a proper position and to translate the mandible into the forward position without bringing the back. How the next bite is a section or how the inclination is a transfer over the bite block. On the lateral position, you can see it is almost 70 degree to the occlusal plane. The inclination in the upper plate is start either between the canine and premolar and the terminate into the lower before the first molar start. So the eruption of the posterior teeth and first molar will take place when you do the posterior bite block trimming. Or even you can inclination incline plane can start between the upper premolar and should terminate before this first molar start. In a horizontal plane, either it should be right angle to the mid palatal suture. You can see on the occlusal model on the lower left side, or it should be a right angle to the central line of the occlusal in the posterior aspect. When you are expanding the upper appliance, it should be that the plane should be right angle to the mid palatal suture so that uninterrupted expansion can take place. This is the appliance. Have a anterior bite block and posterior bite block, and you can see the indentation into the occlusal in the upper bite block, and see the lower bite block is terminated before the first molar start, and into the upper appliance occlusal inclination start between the first premolar and the canine region. For finishing and polishing and the carving of the bite block, it needs a certain burrs that I've given into the picture. Stainless carbide trimmer, alpine stone, sandpapers, scotch bright, and the metal brush. These are the use for finishing, polishing, and carving of the bite block. These are the finished appliance. First picture will show the how it is a meat part into the upper appliance is a finish. The separating line in the upper is also a bevel so that as you expand the upper upper appliance, there is a gap, and many a times the sharp edges of the upper bite block may irritate the tongue, or as well as it may hurt the palatal mucosa also. So it should be a bevel and finish well. In the upper appliance, you can see the occlusal trimming is given. In the anterior region, it is a narrow, posterior region, it is a broader, and your natural dentition is there. Interproximally, also embrasure area is also a curved, so that food excursion and the efficiency of the swing can be maintained. And secondly, to maintaining the occlusal anatomy into the appliance, the proprioceptive mechanism is established immediately, and patient are very friendly here even during the mastication. In the lower appliance, the appliance is not designed to cover the incisor edge, but it is a rest over the incisor edge, and it is a help into this to make it more cheering of the food into anterior aspect. Regarding the thickness of the appliance, you can see the upper appliance is almost 2.5 to 3 millimeter all over the thickness to maintain the strength, and even in the screw area, the thickness of the appliance should not be more than 5 millimeter. For the lower appliance, it is extended up to the last erupted molar, and look at the border. It is very smooth and it is curved throughout without creating the trauma to the mandibular mucosa. These are the same appliance on the different angle on the upper as well as the lower model. You can see the inclination into the upper block, both the side, right and left side, how the clasp is properly adapted. Look at the lower appliance. It's interdentally by the eyelid clasp, Adams clasp on the first premolar, and a half C clasp on the lower first molar. Engaging the last molar that hold the appliance properly and that control the further flaring of the lower incisor. The same appliance, look at how they occlude the anterior. The lower block is touching to the upper incisor so that it helps in the tearing of the food. Posteriorly, you can say it is the cusp to groove occlusion, buccally as well as the palatally. So efficiently patient can chew the food immediately. The standard design of the twin block appliance, which is given by the Dr. Clark in 1977. He has given the delta class on the first molar in the upper appliance and Boland class between the premolar and the canine. In the lower appliance, delta class on the first premolar and Boland class between the canine and premolar. See, twin block appliance is a tooth and tissue bone appliance. Secondly, it is used under the mastication also, so it needs some stability and retention both. So addition of the class will help to maintain the appliance very firmly, and during the mastication, they help to stabilize the appliance. So you can add the additional number of the class. These are the one of the modification of the standard appliance, having a label bro from the premolar to premolar in the upper. Additional eyelet class given between the canine and premolar region, and the label bow is passed through this eyelet. So the label bow became a very sturdy. They cannot be slipped, neither from gingiva nor from the occlusally, and they give the better retention. And the design of the label bow is adapted label bow that will help to avoid the flaring of the upper incisor. Secondly, half C class between the canine and premolar, between the first and second molar, and the eyelet class is given between the first premolar and the molar. This class can be removed as soon as the patient is adapted or during the trimming, as and when you require for the eruption of the posterior teeth, and you want to need a closing the posterior bite. For the lower appliance, each and every embrasure is occupied by the eyelet class so that it gives the firm retention and they control the flaring of the lower incisor also. And then when the patient is adapted to wearing the appliance and you start the occlusal trimming, you can remove the clasp between the first premolar and the molar so that the eruption of the posterior teeth, lower molar, can be started. Appliance delivery. First of all, upper and lower appliance should be a check onto the patient study model. There should not be any nodules, nor it should have any bubble over the occlusal surface or over the tissue surface. It should be well finished. If you run your finger over the appliance on the tissue surface as well as the over, it should remain a very smooth without any sharp margin or any point. Once the appliance is checked, it should be delivered within the 2 week time of the impression. If you make a delay, there may be some eruption of the posterior teeth, either erupting the 7 or erupting the canine or first premolar, may create the ill fitting of the appliance or may not be comfortable to feed to wear the patient. Postpone all the extraction until the appliance is delivered. Once you take an impression and start preparing the appliance, one should not support to create the any extraction until you deliver the appliance. Arrowhead class could be a passive at the time when delivered. The class should be adjusted during the appliance delivery for firm retention and stability. Lower lingual extension to be inspected for the potential soft tissue trauma, specifically the lingual frenum area. If it is overextended in the anteriorly or overextended posteriorly, there is a whole chances of the trauma to the soft tissue and may create the traumatic ulcer. So one should be careful about the lower lingual border. Troubleshooting factors during the delivery. Check for the high part using the articulating paper and perform the selected trimming if needed. After putting the appliance, one should be check the posterior occlusion. If there is any high part, you can check by putting the articulatory area, and the block should be properly balanced from the lower molar region so that patient is able to close properly and comfortably and chew. If there is a lack of retention, label bow, clasp, and expunge screw can be activated and adjusted. If there is a gap between the posterior block and upper teeth, or there is a gap between the inclined planes, you can correct it chair side by isolating one of the inclined plane by the sellotape and hold the cockpollicle intraorally and ask the patient to close the mouth. Patient instruction. See any of the removable appliance, patient must be motivated fully. Before you convert the patient for the myofunctional appliance, you should ask what is the limitation of the twin block appliance, what is going to happen for initial 3-4 days, and what is the outcome of the myofunctional therapy or twin block appliance. And this is a wonderful technique. You can do the things without any surgery, even in a severe skeletal deformity. So ask the patient to wear round the clock. If you put the appliance during the mastication, it creates almost 700 grams of the pressure. And 1 millimeter of advancement of the bite by registering in the wax bite will create the 100 gram of the pressure every millimeter. So if you have added on the 10 millimeter of the mandible and patient is wearing the appliance during the mastication, there will create about the 1,700 gram of the pressure. That is enough pressure to elicit the skeletal changing into the ramus and condylar area. So in almost all my patients, I advocate to wear the appliance, and most of my patients, they are ready to put the appliance during the mastication also. If your posterior bite block is flat and not properly adjusted to when you deliver, patient may not be comfortable to chew the food. So that factor should be come into the point. Textbook recommended use the twin block during the meal. Some random control trials suggested there is no difference in the effect of the twin block appliance if not wear during the meal. But in my patients, those patients who are wearing round the clock, they have a faster improvement than the patient who are not putting the appliance during the meal. Remove the appliance after the meal for the brush and teeth and the appliance. So after every meal, the appliance should be thoroughly cleaned as well as the appliance and teeth should also be cleaned properly. Otherwise, there is all chances of the decalcification during the course of the treatment. Many times, if you cover the incisal caries can be occur even in the posterior, upper posterior area. If the block is not properly cleaned after every meal, there is also chances for the decalcification of the upper occlusal surface. Problems are encountered in the twin block appliance. As soon as we put the appliance into the patient mouth, there is the excessive salivation, and this is because of the foreign body sensation. But after few hours, the higher central will recognize this is the twin block and not this is the food. So the impulses from the higher center to the salivary gland will be stopped, and the excessive salivation will be controlled within a day or two. Reduce the masticatory efficiency. So ears together, he has chew in the retruded position. So the muscle of mastication are used to or habituate to create the movement of the during the mastication. But as soon as you put the twin block appliance into the oral cavity, all the oral cavity changes are take place into the movement of the mandible, joint, masticatory muscles, tongue movement. So the masticatory efficiency will be reduced for few days. You can ask the patient to start with the semi-solid or soft dough, and progressively you can start the roti chapati. And within a week period of the time, patient can master with the regular food, with the regular time and regular efficiency. Speech impairment. This is one of the factors for a few hours or a day because of certain area is occupied by the twin block appliance. Secondly, there is a change in the posture of the mandible, so the movement of the tongue, palate, and certain pronunciation that occurs because of the movement of the tongue, palate, and teeth may be hampered. You can ask the patient to read loudly textbook or any storybook, or you can sing a song so that there will be a practice and immediately speech can be regained within a 3-4 days or a next day. Patient instruction after the delivering the twin block appliance. Highest standard of oral hygiene has to be maintained. Incisal capping can lead to the decalcification of the incisal edge, or even the occlusal surface of the upper posterior teeth may create the decalcification because of the if the patient is not properly clean and not maintain the proper oral hygiene, will lead to the decalcification and caries. Brushing after every meal is mandatory. Fluoride toothpaste or mouthwash are highly recommended. Denture cleaning sodium perborate tablet are to be used once or twice a week to clean the twin block appliance. These are the case I have just finished few months back. Uh, Look at how the expression before the treatment and look at how after the advancing the mandate skin tone is changed. Look at he was allergic to someone. Look at the eyes and everything. These are the intraoral picture before and after. There was a mild imbrication in the lower as well as the upper teeth. Class full class two division one malocclusion. Canine is also in a class two. After twin block appliance, there is a spacing in the upper. Crowding will remain, mild crowding will remain as it is. Molar became a class one, canine became a class on the both side, and the patient was happy, and there was no need for the any 6 apply setup. Thank you.